Okay, welcome back. Oh, my goodness.
Hey.
Hey, welcome to all five of you. We're so thrilled to have you join us again.
Yeah, we're just going through the numbers of our podcast reach across this great and crazy planet, the internet. And
That's right.
18 of you have been impacted by our last episode.
That's right. Just imagine. Well, I think kind of like if you just listen to this podcast long enough, we'll eventually have you on as a guest. We're just kind of
yeah, that's right. If you're a listener, send us an email, emotionalmenpc@gmail.com.
Yeah.
But we don't need to scrape the barrel of our fan base. We actually have a great guest here.
That's true. Well,
I'm a guest. I don't know about great. That's
great. This voice belongs to that of my little brother, and this is very much a nepotism hire.
That's right. Nepo baby right here.
That's right. James McCarrey, Dr. James McCarrey. Let's see here. Let's see how I can do off the top of my head. I know you just gave us everything, but I don't listen when you talk. So let's see how much of this I can. Okay, so you were born in 1989, in August. See? All right.
He didn't say that. This is just coming from Taylor now.
That's true. All right. So born in 1989. And then let's see here. Started school in Pasadena, moved to Everson, Washington, went to BYU for your undergrad where you did exercise science?
Yep. And a minor in Spanish.
Did you really?
Mm-hmm.
Oh, sehr gut.
Yeah.
Yes. I know James and I have been in bands together before. James is a very talented bass player and guitar player and singer. James also did improv when he was in high school. And there's a video I remember watching him in a hat and a suit coat walk around a stage going, blah, blah. It was a lot of fun.
I don't remember that, but okay.
It's knocked in the old noggin.
When he said he remembers what you said a minute ago, he remembers everything you said.
This is the problem of being related to a therapist is I remember none of the details, but every detail of everything you've ever said. After BYU, where you met your wife, you went to Lincoln Memorial in Tazewell, Tennessee, which is about 40 minutes north of where Pete is right now. Is that?
Hour and a half.
Hour and a half
north. Okay.
Yeah.
How long were you in Tennessee then, doing the med school?
4 years.
Okay.
Yeah, all 4
Solid
years.
4.
Yeah.
And then you went to
Tennessee.
Harrogate.
Yep.
And then you went to your residency in Iowa or Indiana or
South Bend, Indiana.
Oh, okay.
Not affiliated with Notre Dame.
Is that the name of the school?
Well, Notre Dame is in South Bend, but it doesn't have a med school, so it actually can't sponsor a residency. So even though saw a few Notre Dame students and stuff, we weren't affiliated with them.
Technically, James didn't live in South Bend. James lived in Mishawaka. And this is important because who else is from Mishawaka?
Adam Driver.
Adam Driver, Kylo Ren himself.
No
went
way.
to Mishawaka High School.
Yeah. Home of the Cavemen, if I remember their mascot correctly.
Okay. That's fun. Yeah. James is right now in Windsor, Colorado, just to the southeast of Fort Collins, right?
Yep. Kind of right on the border. It's weird because my zip code will say that I live in Fort Collins, but I don't.
Are you doing private practice? Are you working in a hospital or?
I work for a hospital system. I work for a hospital system doing all outpatient family medicine. Been working here for almost a year and a half. And then, so I graduated med school in 2018. Residency was 3 years. Then I did 3 years working for that same hospital system afterward. And so I'm in my 5th year outside of residency practicing.
All right. Well, I got a lot of questions for after the podcast because I have
that include the words, does this look infected?
Yeah, something like that. Yeah, but I'll talk to you about it later.
Okay. Once the recording is off.
Yeah. I feel sorry for James because I know for a fact that my dad will always be like, well, I talked to James about this weird thing. And I just go, oh, man, I hope that James gets phone calls from people that aren't just, is this normal?
Trying to abuse him.
I gotta say, like, I have to acknowledge and admit that I am guilty. There have been a time or two where I'm like, hey, James, what do I do with this thing? And like, he doesn't do it, but I can hear him in my head, like rolling his eyes so hard to go clunk.
Yeah.
No, as long as it's not a picture of your junk, I'm usually okay answering medical questions. So
No,
Keep
we
it
stopped doing that
professional,
years
James.
ago.
Gosh.
Yeah.
That was even before you went to med school.
Mm-hmm.
yeah,
That was more about just making sure he knew the hierarchy.
Hey, just so you remember, I'm the older brother. Ta-da! Ba-bling!
yeah.
It's so weird.
Not penis related, but one thing I will say is that James is the only of my siblings who's ever been taller than me, and we're talking like minuscule amounts, but he has been taller than me, and I don't think I've ever said this in public. I think James can hit harder than I can. James has punched me before, and I was like, holy crap. Homie's packing some heat in the arm. Like, we've never gotten into a fist fight before.
No.
Okay. Well, good for you, James. I'm glad to see that Taylor's humbled, at least physically, every now and then.
Yeah. At least every now and then.
Yeah, every now and then. But I like to tell myself things to make myself feel better about the fact that he's a doctor and I'm not. I don't know what those things are. James, my question's for you before we dive into the real meat of this. So today we're talking about the correlation between mental health and physical health, which is different from talking about physicality or physically living your life. I'm curious, how did you decide to go into family practice medicine? Because I remember at some point you were talking about cardiology. Why family medicine?
So initially I thought, cardiology would be really fun. And then honestly, I rotated with a cardiologist and thought I could not do this every day. It just is too repetitive. It's too much the same thing every day. Little did I know that every specialty kind of ends up being that way. But in family medicine, for those who aren't aware of the specialty, it's primary care. I take care of from the cradle to the grave, from newborns to end of life. And so in my mind, I enjoy the variety that brings. So I get to see, everything really, kind of like the first line of the medical system should be good primary care.
I was wondering, you're like the landing pad for all medical issues, and then from there, if it's more severe, they go to a specialist from you.
Exactly, yeah. And honestly, the way I see it is I try and avoid sending people to specialists if I can, just because it adds a lot of cost and time getting into folks and everything there. I mean, another thing that I thought about also when I was trying to choose a specialty was that where the greatest need was. And I know that in primary care, there's just such a lack of it everywhere that I would essentially always have a job wherever I wanted to go. And so I at least in medicine among doctors, there's kind of like a hierarchy of, which ones get the most respect. Like cardiology, definitely way up there, kind of down towards the bottom in general is like pediatrics, family medicine, and everything.
Really?
Why?
Yeah. We're the least paid specialties. It's not as glamorous. We don't do a lot of procedures and things like that, but
is it like bloody noses and sprained ankles and stuff? Like you don't have to play.
Yeah, like I mean, even that, people generally go to urgent cares. I don't see a lot of like bloody noses and things. But I honestly don't know why that is. There's just a great need for primary care. I think the administrative burden draws a lot of people away from it. Also, knowing that you can make a lot more money in other specialties is.
It's crazy though. Like James is talking about, we don't see a whole lot of stuff. I've heard some of the stories of what James has seen and gone through, and I'm like, that doesn't sound like nothing. I mean, James has talked about stories that involve being covered in blood and holding somebody's internal organs in his hands.
Yeah,
surgery rotations. But, yeah, I mean, also, I think my personality, I would not fit in with surgery. Just like I am not that like. This is a stereotype, but in my experience, I'm not much of that. I don't think, but I also don't have like a very strong like God complex, which a lot of surgeons have. Like, it has to be this way. I can fix it, and only I can fix it, kind of thing.
Fighter pilots have the same thing, but it's understandable. If you're going into a surgery, I would want somebody who truly believes that they can do it. Like, there's no plan B, there's no other way. It's just, I'm going to do this because I'm amazing. And if I'm giving my kidney to somebody to fix, I'd be like, okay, thank you. Yes. I want that person to be like that.
Yeah, let's not hang out afterwards.
Mm-hmm. Yeah. I mean, I think from a medical perspective, I don't think there's a lot that I do really amazingly. But I know the one skill that I do have that I do exceptionally well is I listen. And in surgery, that would not be really something that is really a skill that is praised. I don't think very much in like in surgery in general. That's kind of like get in, get out, fix the thing as quick as you can.
I've ever been to. Like, my favorite doctor I've ever had was in Seattle, Dr. Bressy. Oh my goodness, I still lament moving away from Seattle just because I miss Dr. Bressy so much. Man, he knew how to listen. He was so good at going, what's the problem? And then waiting until you were done talking and then pausing to make sure you were done and then giving a thoughtful response. Worth its weight in gold, which is kind of the secret to being a therapist too. If you can just shut up and listen, which, James might have been surprised to learn that I was capable of doing that when we were younger.
Wait, Taylor, you want to be a therapist?
Are you sure about that? You've got some. It's interesting talking about like the God complex of surgeons. I feel like at least between the three of us, you have to have some level of light arrogance to tell someone I can do what you need me to do. Like, someone will come into my office and say, like, I have deep trauma that I need help with. And I can say, I could do that. I mean, that's a bold statement, and people can go into James's
office. That could come off
say,
as arrogant. Yeah.
It can. Well, I don't. Yeah, and I think.
But it's true. I mean, you could say, I know the modality of treating trauma. And I've seen a lot of success from it, and we can do that. If you're willing to put forth the work, we can do it. Someone will be like, well, how can he say that? Who is he?
Yeah. Well, I think the difference between arrogance and confidence is whether or not you think you're better than the other person just because you have that skill. I mean, that's part of my good at 4 or 5 things. Like, I'm good at these things, but that doesn't give me any more intrinsic value than you.
Yeah, maybe the arrogance comes off as assumption of like better than, but it's not about being better than, it's just capable.
Yeah, I guess that is kind of more what I've seen in a lot of surgeons. They just feel like they come across as they feel like they are better than you because of their surgical skills.
Which is funny because I feel like maybe this is just orthopedics, but I feel like the cliche about surgeons, maybe just orthopedic surgeons, is they're kind of like boneheaded.
Yeah.
One day we're going to have an orthopedic surgeon on here. We will.
And I'll tell him that he comes across like a moron. I have no problem with that.
I can juggle.
Pete, see? Nobody cares.
Oh man, I'm better than you.
No, you're not. On so many levels. You have no hair, you're shorter, you're still in school.
Still in school. That's a good one. It sounds like I'm bringing a lunchbox.
Yes. I like that because I said a few minutes ago that I'm the least educated person. It's a real ballsy move to punch up like that.
Yeah, I'm trying to make it up between me and Taylor. Anyway, I feel like we should bring in why we brought James in. Let's move into the topic.
And I will say also to any surgeons who may or may not be listening, I do appreciate you guys, what you do. I'm not trying to disparage you guys. It's just...
That's Dr. James McCarrey. Phone number is 360.
Oh, man. You just alienated all your referrals.
Yes. So for serious questions, though, I know some of the stories you've told me, James, and they're ones where I'm like, ooh, that could be legit trauma you just went through. I'm curious how you as a doctor manage your own mental health. And what I'm not asking is for a rundown of any kind of mental health problems you may or may not have. I am curious, though, what it's like to see people suffering and still want to go to work. I know how I do it, but it's different because you see physical suffering.
I would say as a whole, doctors don't do a good job. And I'm guilty of it too. I mean, I can think of a few times in residency after pretty gnarly codes where like every chest compression is just blood shooting out of the person's mouth, or after another time where I had a patient of mine that we had delivered. We'd been laboring with her for, it was a preterm delivery. And anyway, she ended up bleeding out essentially during the cleaning out of everything. And like that, I feel like after that, I was pretty traumatized. Like I know like felt like I was on an adrenaline rush but it wouldn't calm down for at least a week. Um, and so in residency, we're kind of taught though, I mean, like that code that I described, I was on call, get called up to that, and then immediately have to go down and admit someone for something completely benign that ended up not being anything. And it's like, you don't get any time, at least during training, to sit and process that. And I think as a whole in medicine, we just kind of, well, move on to the next one, and try and forget it. But I've been trying to, at least when things do linger with me, I try and figure out why is that lingering with me? Like what is hitting me so hard about that? And so I'm not ashamed to say that I've been to therapy. I have my own mental health issues that I struggle with. Um, and so I think in answer to the question, like, how do I handle it? I try and, as much as I can, leave work at work, um, and try and, as much as I can, at least, be at home and be present at home and appreciate my kids and everything, especially after seeing some of like the truly horrendous things that have happened.
So it sounds like from
kids.
even the beginning of your training, you're trained to compartmentalize. Like this death of someone on your table happened in that room or at that time and is not at all related to the next person. You have to admit there, and you like mentally section those things off. And so
Yeah.
you do it between work and home, you do it between patients, you do it between floors of the hospital. Like you just are putting things in boxes and they stay in those boxes. That's my
Yeah.
perception of what's happening.
Mm-hmm. Yeah.
And that story with that lady, I think I heard you saved her life, didn't you? She lived, didn't she?
Yeah. I mean, to kind of give the whole story, what was partly traumatic for me about it too was that my wife, Soraya, was pregnant with our third son. And she had two C-sections, and this patient that I was caring for had two C-sections as well. They were roughly the same gestation. They were both about like 20 weeks along in the pregnancy. And then my residency was a bit different in that when one of your patients was admitted to the hospital, you were responsible for caring for them, even if you were not on an inpatient service. And so that included obstetrics as well. And so she got admitted one night at like 21 weeks or so because her water had broken. And so at that point, there's really not much that can really be done. She's probably going to lose the baby. Like there's a 99.9% chance of losing the baby because of infection. We told her that you can go home. And then like a day later, she came back and she had a horrible infection. Baby was still alive and we had to induce labor. Um, and so,
Jeez.
uh, and that when people talk about like need for abortion, and things like that was, it's either we do this or mom dies, baby is going to die regardless. And so uh, we induced her. It was like 3 days and 3 nights that I was in the hospital. Like I stayed overnight for 3 days and 3 nights. And then basically she delivered, the placenta was retained, and it just kept bleeding and
Ooh.
bleeding. And I remember being in the OR, we're just with the surgeon who was on call, the OB who was on call, and she's just trying to get everything under control. We finally get it under control and we're closing and leaving. And the anesthesiologist kind of all of a sudden just drops her, uh, so that her head is down to kind of get more pressure into her head. And I'm like, what's going on? And he's like, her vitals all of a sudden just like tanked. And he'd been giving her blood and stuff all throughout the surgery. And I couldn't feel a pulse. So we started doing compressions. We got her back. And within a week, she walked out of the hospital alive. So
it's freaking insane, dude.
Wow, that is from the brink. That is, oh
yeah,
man. If this were a movie, you just
it's,
keep waiting for the worst to happen. Just
yeah, it's just like it was in the middle of the night too, and I had to like I got along well with her and her husband and had met her kids and things and like going to tell her husband like, hey, like we lost your wife, we've got her back, we're
Oh
moving
my
her to the
gosh.
ICU. Like going through all of that was not pleasant.
I bet.
Kind
I
of
feel like one
kind
of
of
the
hard.
the really weird things that certainly you can understand, James, but I think Pete and I understand to maybe a lesser degree is like the feeling of knowing there are people who are alive right now who would not be alive if you specifically were not there at that time blows my mind. That's crazy. Absolutely crazy.
Yeah, I mean,
Hmm.
at least I don't kind of look at it that way because I feel like someone else would have been in that situation and the
Sure.
right thing would have happened.
But that doesn't change what you did.
Yeah, that's true.
Yeah. And you get to carry the memory. Lucky you.
Yay.
Whee!
well, I don't know if this is a genuine yay. Like I'm feeling good about this story, but then the sarcastic yay at the end. I can't tell if you guys feel good about this story.
I
You were there. You saved someone's life. She's alive. They were probably desperately pleading to save his wife and these two kids, their mom, and then she made it and she walked out of the
yeah,
hospital and you went
Walked
on
out.
to the
That's
next patient.
insane.
Walked out, yeah. And you went
yeah,
on to the next patient and she went on with life. Man, how beautiful.
yeah. It was I think the more I'm happy with the outcome, I just know how that affected me mentally. And that's where
Hmm.
the sarcastic yay comes from. It's more that screwed me up for a good while.
Also, like
How could it
even
not?
the win was not really a win. It didn't feel like a win.
Yeah, it was because I mean, at the time, if I remember correctly, when that was going on, I was on our inpatient medical service, and so like in between staying and rounding on her in the hospital, I was rounding on other non-pregnant patients in the hospital as well, being on call, admitting people, doing codes and things like that. So that was extremely stressful.
Hmm. I feel like it's kind of analogous, like Frodo. He got rid of the ring, but man, he sure paid a price for it.
Yeah,
James is a
yeah,
big Lord of the Rings nerd, by the way.
Okay, I was
I
wondering
am.
where
Yeah,
this came from.
yeah,
Like
yeah,
it's like
yeah,
Frodo. Man, that's deep.
I'm just
What?
speaking the
yeah,
language he understands.
Okay,
yeah.
got it. Dang it, I need to dive into my nerd trivia.
Yeah, James has a really great shirt. It's the Mordor Fun Run 5K.
One does not
That
simply walk. Yeah.
yes, yes. So I'm curious then, knowing that you have a predisposition for mental health issues, but also knowing you personally, knowing that you are a capable, competent, functioning human being, clearly
Mhm.
you've got it at least under control enough to still function. I think probably well under control. I'm curious how you have seen any correlation between how your mental health and your physical health have become intertwined.
I would say, do you mean me personally or like among patients that I've seen
Yes.
or either way? Okay. I know for me personally, like if I'm taking care of myself physically, particularly exercising and eating well, that I overall feel better. Because I get like weird stomach issues too. Anyway, I just feel better overall when taking care of myself, not only mentally. Um, I think as I've been kind of thinking about the topic, the relationship between mental and physical health, what interests me more is not necessarily how good health uh, can lead to good mental health. I think what's more interesting is the relationship that mental health has on physical health and the way that it can
Hmm.
overall impact everything. Because as I'm sure you guys have seen in helping folks, I mean, I see a lot of depression and anxiety. I'd say those are probably the two most common mental health things that
Sure.
I see and that everyone in the mental health profession sees. But when someone is extraordinarily depressed or extraordinarily anxious, how much that impacts every other aspect of their health. And
Hmm.
it keeps
Yeah.
them, particularly like with the depression, if they're really low and not motivated to do anything, not having the energy, really have severe anhedonia, just like they're not going to exercise, they're not going to probably want to eat right. And that just kind of sets off a downward spiral that was probably triggered by the mental health as opposed to other things going on.
Does that mean then that you feel like you can use physical health to treat mental health issues, or do you think that mental health issues override physical health issues, if that makes sense?
I think that it could go either way, honestly. I mean, I think that depending on the severity of the mental health, it could definitely lead to uh, really bad health overall. But I think that not necessarily having bad health leading to mental health problems, because you run into folks who have a lot of horrible illnesses going on, but they have the greatest outlook, like they're the most optimistic people ever, and seem to have it all together. And you just kind of wonder, like, how in the world are you doing this well from a mental standpoint when your body is falling apart? And so,
I would say there's a differentiation, and in some of the research I did, that what's important to what I found interesting was the difference people put between physical activity and physical health. So to be mentally healthy requires physical activity. And in 1954, the first director general of the World Health Organization said, there's no physical health without mental health. And so they've researched physical health and mental health for a long time. There's a lot of research to back the fact that physical activity indirectly affects mental health. But not, I mean, enough physical activity will make you physically fit, but it's not necessarily about being fit. It's not like being healthy per se. It's about physical activity and being in touch with your body and being physically active and caring, not necessarily about when I'm shredded, then my mental health will be awesome. In
fact, one could say that the most shredded people are usually the most mentally unhealthy because of the level of everything.
Oh yeah,
I've never met
expectation
a happy person
and anxiety and stuff. Oh man. But I would say I worked with one guy when I was in hospice, and I think I've told this story, who was severely depressed. And when he walked into his apartment or his hotel room, it was a depressed person lives here. It was his thought. And I asked him, what would it do if your bed was made when you walked in? And he said it would be awesome because the bed is the first thing I see. That would make me feel a little bit better. He didn't say awesome. He said that would make me feel a little bit better. It's the first thing I see. So we talked about that, despite being depressed and horribly depressed, just making your bed. And he decided to do the dishes. So we talked about things that need to be done. Doing the dishes was important for him. And we didn't get very far because of his cancer and the work we did, but he reported that doing dishes helped. It was just the fact when you look at your counter and there are no dishes there and you feel better. And the fact that you're cleaning, he felt better about himself, his situation, as he has soap on his hands and as he's doing the dishes and doing what he should be.
Yeah.
What is the phrase for that? Sweat equity?
Sweat equity. That's right.
Yeah. I mean, I had an attending who, in residency, he would say, I'm at the point where I no longer exercise for my physical health. I exercise for my mental health is kind of the way that he put it.
Mm-hmm. It's a good way to put that. I want to bring up something that I think you guys would have some thoughts about. In 2017, a couple of researchers surveyed 10,000, almost 11,000 people over 50 years old in England, and they found that physical activity is the largest contributor to indirect effects of mental health because it is not a direct.
Can you tailor that down for me? It's been a while since I've asked you to do that.
So, also, as we're talking about physical activity as an effect construct for mental health, it is indirect. Directly working on your mental health is doing things directly for your mental health. Physical activity is by nature for physical health. So it's indirect for mental health. So this study basically took survey data of 11,000 people and found that that physical activity in terms of indirect effects was the strongest way to affect your mental health. And it was up to like 10%. Now, when I say 10%, that doesn't sound like a whole lot, but if you've talked or if you've experienced depression and those weeks of overcast days when you are at 0%, the difference between 0 and 10% emotionally is a big, big difference. Feeling okay is amazing when you have not been feeling okay for a long time. So I think 10% in terms of indirect effects is quite significant.
Yeah.
Yeah.
And kind of talking about the role exercise has, I know that I was reading a review for like depression treatments there, and one of the newer guidelines I saw was actually that for mild to moderate depression, exercise, like a tailored exercise program, is one of the first line recommendations for that, because it can be just as effective as an antidepressant, or therapy. I mean, it doesn't replace those things, but it certainly can, indirectly, like you said, because you get the endorphins, and when you're exercising, you feel better about your self-image and everything. And so it can definitely help with mental health in that regard.
It might also be your expectation going into it. These longitudinal studies I did were completely like they were not assessed in correlation with each other. They were just like, tell me about your mental health, tell me about your physical activity. They found over the course of 11,000 people, they found to be a substantial correlation. But if you're given by your therapist and you're saying, we're going to do therapy and your walk every night, I want you to walk half a mile every night, is going to be part of your therapy regime, you're going to go into that walk with a whole different mindset of why you're walking, what you're doing it for, what are you going to be thinking about during the walk, all that stuff. It's not completely unrelated. So I think when you're given physical activity as a type of therapy, it could be a direct effect. Maybe. I don't know.
When I was in my undergrad, one of my professors, the guy Matt Draper, love him to death. He changed my life. But he talked about a study. This is purely anecdotal at this point, but he said that he was aware of a study where they had college students. There's the scientist people. What's the word? You've got the two groups. Oh my gosh, what is
control group? And intervention.
Like okay. Dumb guy right here. So you've got your control group and your non-control group, which is, just make me sound as stupid as I possibly can. But the control group did their thing. They didn't change anything. But the experiment group, they had a sleep routine, and they had a diet, and they had an exercise routine they were forced to do. And that was the study to see how it impacted mental health. And the reason it's anecdotal is because they had to stop the study because everyone in the experiment group dropped out because they felt so much better. And I think about that from time to time, because I think it certainly rings true with my experience that if you can I tell people, depression is momentum. It's just you stop, and it just takes way more energy to get any kind of movement going again. If you can get the movement though, and you can build up momentum through exercise, through good sleep habits, through good diet, the momentum starts to build up, and eventually you're not sitting still anymore. The depression is moving through you and around you, but it's not stuck inside of you.
It's an important point. Depression doesn't just leave and all of a sudden you're a different person or whatever. You learn to live next to it without it being inside of you.
Yeah, I feel like, and sorry to cut you off, James, but I feel like I do cycling. I like to ride my bike, and I think the greatest gift that cycling has given me, like it's an endurance athletics thing, and the greatest gift it gives you is endurance. Like the number of times I've been in a situation and thought, I don't want to do this. I have zero energy. I'm not excited about this. But I think back, there's a specific hill in Kirkland, Washington, that is like 1.5 miles, 2 miles long, that it's interminable. And the feeling that I could do that, I can do this.
James is thinking about that right now, probably. Sorry, James.
This is interminable.
This interview will never end.
Why were they still talking?
No. It's interesting. I mean, you mentioned those three things, like the sleep, exercise, and diet. Like it's interesting here when people are like trying to get perfect health, and I'm like, and doing all sorts of like crazy things and that aren't entirely evidence-based and all sorts of things that kind of different out here from what I was used to in Indiana in that regard. But how much I just tell people, look, it's just the three basic things. You get those down. If you eat well, exercise regularly, get quality sleep, that your overall health is going to improve. It may not be like a dramatic thing, but you can't, if you're striving for perfection with your health, you're just not going to get it. It's never really going to happen. And you're going to stress out about that more than you would if you were just kind of enjoying life with the quality that you have doing those three things.
It's always the regular, boring things you don't want to get good at because it's monotonous, and you have to get better to keep it going regularly. And it's just not, it's not fun. It's not sexy. It's not quick.
Yeah. I was going to say, yeah, that they're not the sexy answers. It's not like a vitamin or a pill that you can take as like, boom, more energy. It's those things, those habits. And like I always tell people, like, just make a small change, just like a tiny one. It doesn't have to be a big one. Like I tell people all the time, we suck at making dramatic habit changes. Just pick one tiny thing that you can stick with. Because I do a lot of weight loss counseling as well. I see a lot of that. And just like tell people, like if you're eating out 4 or 5 times a week, cut it down to 3 or 4 times a week. That way it's not overwhelming, something you can stick with. And that small change can lead you to other bigger changes and bigger outcomes in the end. So,
oh, absolutely. Like we're kind of circling around an idea that, yeah, it's not a big, dramatic, sexy change, but I'll tell you what, man, like if you can do those small, non-dramatic changes over time, there will come a point in time where you do a big dramatic thing and go, there's no way I could have actually done that forever ago. Like when I was on my mission way back in the dark ages, I had this push-up contest, a push-up thing I did where for 1 week, I did 3 sets of 5 push-ups. And then for 2 weeks, I did 3 sets of 10. And 3 weeks, I did 3 sets of 20. And I just kept doing that. And by the time I was done, I was doing 3 sets of 80 push-ups every other day. And like, it was just so boring. I stopped doing it. Like by the time I'm in the 3rd set, I'm like, I don't like this. But my whole life, I've never been able to do a pull-up either. And so I'd say by the time I was doing 3 sets of 60 push-ups, I was at somebody else's house and they had one of those pull-up bars. And it was one of the ones where like you could grab it like this. So like there's the front grip, there's the back grip, and there's like the side grip, I guess. And so they said, hey, see if you can do a pull-up. I went, okay. And so I grabbed it with the side grip and I like pulled up as hard as I could. And I shot up so fast, I almost hit my head on the ceiling. Because I didn't know that I could do that. Apparently, those muscles are the same ones I've been working out with the push-ups. That felt pretty dramatic to me, but I don't know at what point I gained that ability. But I do know that it happened at some point from just doing something super boring.
Yep. Yeah. That's like when something takes a hit to your mental health and you've been working on it for, weeks, and all of a sudden everyone else is flipping out and you're the one saying, guys, it's going to be okay, or something like that.
I have a client that I can't name and I can't tell stories about, but I will say they just recently went through some pretty big stuff. And the backstory for this person is they had been through some really horrific trauma. I mean, the kind of stuff that like horror movies are written about. Terrible stuff has happened to this person. And recently, a very sudden, unexpected thing happened that impacted a lot of their life, and a lot of their life they tried to put behind them, just brought it all face to face. And they went through it. And they got back to my office the week after they finished dealing with everything. I said, so you're still alive? And they went, yeah. I said, how are you feeling? And they went, I feel good. I said, yeah, because you've done the work. That's how this works.
Yeah. Yeah, exactly. Mm-hmm. In terms of physical health, we're talking to a family practitioner who focuses on physical health. And so here we are talking about mental health. I think I call physical activity an indirect modifier for mental health, because that's, to hammer everything's a nail. So I only care about mental health or whatever. So James, when you're talking about physical health, what is it that people complain the most about that you think, man, if you would just move, or if you just did some kind of physical activity, you're thinking in terms of physical health, I assume. And so everyone was always assuming that, like, oh, that means starting an exercise regimen or something. Or a prescription or whatever. When you think about mental health then affecting an indirect effect towards physical health and going the other way, what are some mental health things that you assume that people need to affect their physical health?
I think trying to figure out like how they got to where they are. Or why?
Is it the why am I like this?
Yeah. Why are you like this?
Everyone wants to know that. Everybody. Yeah. Why am I like? Yeah, exactly.
I think of it more like there's trauma-based care, which I think like why is the patient like that? Is like at least my basic understanding of it. It's not something that I really practice, but is like why is the patient like this in terms of like the way that they act and everything, and trying to figure out, they probably don't act, especially in terms of like rude patients, like why are they acting rude like this? Why? Because I'm assuming they're not this way all the time, but why is it here that they're that way? And trying to figure out in terms of like their health, how did they get here? Um,
Do
and I
you think
think,
that matters? Do you think mental health, in terms of coming into your office and somebody's complaining of persistent and chronic GI issues or something, do you ever think mental health stuff, or do
oh
you
yeah,
automatically think, okay, well, what are we going to do, like protein pump inhibitors or something?
uh, it depends. I mean, I think a lot of the time though, if you're getting a lot of like cramping pain, like IBS is extremely common, and there is a very clear correlation between anxiety and worse IBS symptoms. And if you can get the anxiety more under control, the crampy pain and everything generally improves to some degree. It's not like it completely goes away, but there definitely is the gut brain axis and everything. And interestingly, I mean, the most common medications we use for anxiety, depression, the SSRIs, the serotonin, selective serotonin reuptake inhibitors, most of the serotonin in our body is not in the brain, it's in the gut. And so,
Well, that's really interesting.
yeah. And so it also kind of helps explain like when people start these medications, why they have such severe gut side effects. It's because you're getting more serotonin effect in the gut. And as your gut gets used to it, it kind of, those side effects go away. Uh, and so I think, yeah, definitely a lot of the time, if nothing else, addressing mental health in the face of poor physical health, it will give you better ability to cope with the poor physical health and the limitations that that brings and causes.
It sounds like with better mental health people, you have a better footing. Like you have more traction on whatever direction you give the people. If they are depressed, they're just have no motivation. What's it called, behaviorally inactivated. They just
Yeah,
don't do. I don't want to take my pills today because what's the point? And that's a mental
yeah.
health thing. I know it's the other way. I asked you like how mental health affects physical health, but
Hmm.
in 2007, researchers found smoking rates are twice as high among those with depression and anxiety. And there was some evidence for improved mental health after smoking cessation programs. You're talking about depression being involved in the gut. Depression and anxiety is also involved in some very unhealthy behavioral stuff.
Well, this kind of
Yeah.
brings up a question that I have, which is for you as a doctor, James, when you look at somebody who's going through depression, but they're also struggling, or anxiety, right? IBS and
Hmm.
anxiety. Let's use that as low hanging fruit. Where is the line for you where you delineate between we need to focus on the IBS and we need to focus on the anxiety? Is there a clear line that differentiates them so you know where to focus? Or is it just kind of like we're going to do a grab all, catch all thing? How do you approach stuff like that?
I think the way in an ideal world, we're able to find the cause of things. And so the way I kind of think about it is anxiety and IBS. Yes, those are two very interconnected things. And so my initial approach would be more, let's get the symptoms of the IBS under control because those can be really painful and can be embarrassing for folks. Let's try and get those under control while also addressing the mental health component. And once we're able to address kind of the root cause, assuming anxiety is the root cause of that, then we can peel off the symptomatic control while maintaining good symptom control through actually addressing the cause of the issue.
So, in general, you believe that physical health stuff is downstream of mental health stuff?
I don't think so. I think there are some cases where that is the case, like IBS and anxiety. Uh, but I definitely think that poor mental health can exacerbate poor physical health. Um, and I think that good mental health can what did I say earlier? I think it could give you the better strength and ability to weather the storms of poor physical health.
Mm-hmm. So it's that traction
Oh, that's
idea
a good,
again.
yeah,
Yeah.
it's a good idea. Good way to say that.
With people, I mean, so we're talking, it's easy for me in my chair to say, well, you're depressed, so let's work on exercising. I understand though that I don't have the training for physical anything. Well, not anything. Anyway, you know what I mean. The point is, when you have somebody who is depressed and has would really benefit from exercising, do you ever frame it in such a way where you're like, hey man, like you could stand to lose some weight, or your numbers are high, your cholesterol's high.
Yeah.
Also, you seem really depressed. Which would you like to work on? I mean, I don't know. Do you ever combine the two in the way you approach it, or do you always kind of focus on physical health and like drop little morsels of this might be good for your mental health too?
I haven't really tied, to patients, at least, like telling like, hey, your mental health sucks because you're overweight and all of that, like because your life choices are
depressed
terrible.
Idiot.
Yeah, get out of here.
I've had friends, a PA who wants to, had trouble with the profession, thinking of getting out because so many things were tied with obesity and poor deliberate health. Like they were just eating wrong and sleeping wrong and not exercising, and he was getting tired of it. He was considering leaving medicine because he was like a broken record over and over again, saying it's all weight related.
Yeah, I mean, it's definitely obesity and overweight. Just it carries so many other things. But what I also tell people when I'm the things to address, like those three things we talked about, the sleep, diet, and exercise, even if you're not seeing weight loss, those have so many other health benefits that, I mean, you sleep better when you're exercising and eating better. You have less mental health, well, I guess less depression, less anxiety when you're doing those core three things. You feel better overall. And it can help your cholesterol and your diabetes and everything if you're doing those three things, even if you're not seeing the pounds come off. I just think there's so many other benefits to those core three things. And I don't even remember what we were talking about just a second ago, but
this is the joy of being a therapist, is taking conversations in unexpected directions and just rolling with it.
Yeah. The question about like, do you bring up mental health as part of your physical like menu to the patient? You're like, yes, oh, and by the way,
I 100% do. I mean, every time I meet a new patient, we have them fill out a PHQ-9 and a GAD-7, so depression and anxiety screening. I think mental health is, at least for me, when people ask like what within the field of family medicine, like do you have like a subspecialty or something that really interests you? I would say that mental health is one of those things to me that I find is kind of where if I were to have a subspecialty within family medicine, I would say probably mental health is it, just because of the way that I've seen my own mental health affect myself and affect my life in general. And knowing how, when that gets better, how much better life can be. And so I don't ever want people to, I 100% address it every time I see someone. And it's always something I'm thinking about.
I did not know that.
That's pretty cool. I think, well, personally, I think it makes a big difference too. And it's not just a why am I like this answer. If someone could answer that question and feel peace within, like, oh, I'm like that because of when I was 10 years old, this thing happened and now I totally understand. That doesn't necessarily fix it, but dealing with it is so important.
Pete always talks about me as a humanist, and I think this is humanism at its core, right? Why am I like this? It's kind of a dumb question. Not to say dumb like you're stupid for wondering, but dumb as in it doesn't actually accomplish a whole lot to have an answer to it. A much more interesting question is, what do we do now that we're here? Right? I mean, like, why am I overweight? Well, we can talk about the choices you made, but like also let's work on getting your weight down. And this is not, again, like I don't want to make it sound like this is about, being fat is the root of all evil in America. Like there's not even close, right? No. It's just kind of low hanging fruit here. But I do think that so much of what is done focuses on to the detriment of the people working through it. If we can find a cause, we can fix it. When we can, but that's not going to fix it. It's just going to give us information to use right now while we fix it moving forward.
Yeah, and some people are really motivated by that too. If you come in and say, "Why am I like this? Why am I this way?" You're like, "Well, like what?" And then you investigate, like, what is the problem? And you say, "Oh, that is name." And you put a name to it. And some people take that as an identity and wallow in it, and they say, "Oh, that's because I'm this way." And some people take that name, whatever it is, depression, anxiety, and take it and work on that. Like, now I know what that is and what direction to go, and I work in that direction. And I think, James, you're talking about, like, if that is a direction that people want to go, more power to them. But in terms of like physical health, that's just one of the things. That's kind of an indirect effect.
If you have a subspecialty in mental health, what do you think the biggest difficulty is in addressing that as a family practitioner?
I think some of the biggest things are just like access to treatment, hesitancy about treatment. There still is a very strong, very big stigma against treating mental health, and that the feeling of that I should be able to get through this on my own without any help is kind of very much still out there. But I think once we come to agreement that yes, there is something going on, and whatever it may be, that getting into either a therapist or medication costs, side effects, things like that, I would say those are the biggest things, the biggest barriers for me. I mean, I'm lucky right now because I actually, the organization I work for has started doing this thing where they make sure that there is a behavioral health person within the office who works just for that office. And so I actually do have a therapist who sees only my patients, essentially, that I refer to her, which is really, really nice.
That's
and
a great
really
resource.
Yeah, it's fantastic because I can get people in much quicker. And I've not really had that before.
What would you tell somebody then if they come in and they're obviously depressed, but they're reporting things like that don't come out as like overly mental healthy type of problems, and yet their presentation is like shut off, not necessarily sad, but just like not making eye contact, like retarded motor vehicle movement in a scientific sense.
Yeah,
So
like
they
not motor vehicle. It's
Yeah.
Sorry, motor
Yeah.
activity. Sorry, not
Yeah.
So they're just not moving, and they have like just the light in their eyes is dead, and they say that they haven't been out of their house in a week, but yet they're talking about like this rash on the right side, and it kind of hurts, but they're just like their whole presentation is whatever. Which I've had the other way around. I'm talking to someone about mental health and they're whatever about a physical thing, and I have to be like, "Oh my gosh." But in your sense, like if someone comes totally not reporting any mental health stuff, how do you navigate that when you're getting the mental health vibes?
Yeah. I think in that case, assuming it's a patient that I've seen multiple times and I know how they normally are, and seeing this big of a difference, I usually ask like, "Hey, what's going on? Something seems off," and just kind of going from there and asking them about it. And once something does come up, I always kind of, especially if it is some kind of like vague complaint, or where my gut's saying this is probably a mental health issue, but they're really wanting to figure out like what is making them so tired or whatever. Um, just kind of saying like, "Hey, we can do all these different tests and everything, but if this all comes back negative, we should probably look at your mental health and see like, is this what actually is driving the physical symptoms?" Um, and so I think it's important, at least on my end, to build that relationship so they don't feel like I'm calling them crazy or saying that their symptoms are just in their head. Because, and I tell people this all the time because patients unfortunately do hear it, that they're told this is all in your head. And it's like, no, even if it is all in your head, you're still feeling it. It doesn't change that.
That just means the illness is in your head. It doesn't mean it doesn't exist. It just means that that's where it is.
Yeah.
Technically speaking, all of existence is in your head.
Yeah.
Yeah.
Yeah. And so,
do you ever get any pushback from people like that when you try to approach mental health, or you try to approach an idea of something you think might be the problem? Do people push back on
that? On mental health, I haven't had too much pushback um, in terms of that. I mean, I've had it a little bit, but it's not usually like that. The first thing I bring up, for example, I mentioned like someone coming in with fatigue, which is just, there are so many things that could be causing fatigue. And so we do the depression screening. If that is high, then I'm definitely going to be following up, asking more questions to see if this is a truly positive screening test, or if this is just, situationally something is going on that is causing these symptoms to pop high on this screening questionnaire. And just trying to dig a little bit deeper, see what's going on. And so I don't even remember the question anymore. I just started rambling.
No, I'm you answered it. You don't get a lot of pushback from people, but I'm so glad to hear that you actually do an assessment after a screener, because a big problem for me as I'm entering academia is we take these numbers at their word. Like these screeners, we screen 10,000 people and we don't validate any of it. We just assume that the number we get and we average it and we find correlations, whatever. And I've had these discussions where it's like, well, we talk to patients and it turns out that it's not depression. It's actually something more sinister, and they're just trying to fuddle the system or whatever. And the answer is we don't look into that. We just take the numbers. Just take the numbers. But when you're dealing with individuals in your office, you have a patient and you have a screener in front of you and you're looking at the eyeballs of the person who wrote it, so important to validate that paper with that person.
Yeah. Because there definitely are times where their score could be really high, and it's because they're sleeping horribly and they have like ADHD and it's like horribly out of control. So that's 6 points right there on the PHQ-9, which already puts you kind of in the mild depression area, but it's clearly not depression. And then there are other times where they score really low and you're talking about like, this is probably not actually this low. Like their depression is probably more severe.
They want someone else to intervene, and so they all just put zeros on everything, and I'm fine, let me go. And you're like, but you are like moist in the eyes. Like you are really sad. Something's going on.
Why did you have to use that word? Oh,
James, was he like this growing up? I don't even know.
Moist? Yeah. What is your word? Isn't it like synthesize? Isn't that your favorite word?
Yes. Oh man, we had a guest say it. Oh my gosh. Yes. This is next level synthesis.
Yes, he's listened to the episodes and synthesized that Pete hates the word.
Oh my gosh. That came out of the lateral.
Yes. What I was going to say is that I think this really highlights my disdain for like the TikTok, Instagram fad of like, oh, I'm so ADHD, I'm so OCD. No, you're not. And it's also when people say, well, I took the PHQ-9, so I'm obviously depressed. No, not necessarily. Like, what you're paying for when you go to a doctor or a therapist is somebody who knows what it tastes like, right? They can see it and they can say, it looks like it, but this isn't actually it because of a series of things that you're not even trained to consider remotely. People will come and they'll be like, oh, like, I have a really hard time paying attention. I'm like, oh, that's cool. So how long were you abused by your parents? Like, how did you know? Because you're talking about trauma, not attention deficit disorder. There's a huge difference. Yeah, exactly. And you can taste it in the air.
I agree. That ADHD, I feel like a couple of years ago, that was everyone thought that they had that. Fortunately, I feel like that fad is gone. And now everyone thinks they have POTS, which is something different. Positional orthostatic tachycardia syndrome. It's like,
wow, scary.
It's less scary than it actually is. It basically means in certain positions that you're standing, your heart rate goes up and your blood pressure goes down. You feel like you're going to faint. Some people faint. Physically, fainting in that way is not going to cause any long-term harm. The harm comes from the falling itself, not the fainting, the act of fainting. And so,
I just found an easy way out of uncomfortable meetings.
Yeah.
The vapors.
The vapors. My humors are imbalanced.
I feel like, at least from the mental health profession, there's always a cycling of like these buzzwords people use, like, like I'm so OCD, you're traumatizing me. Autism was a big one for a long time, and that one always killed me because people are like, oh, I'm acting so autistic. I'm like, autism is not a behavioral disorder.
Yeah.
What are you talking about? Autism is a perception. It's the way you interact with the world. It's not because you act a certain way, you moron. Kills me. Kills me.
So we found the equivalent of moist in the behavioral, in the therapeutic world.
Oh man, Taylor's eyes roll like I did for the first few in synthesis. I think I just found the word.
Yes, there are definitely things that bother me in the same way, but I don't understand why you don't like the word synthesis, because it's a word that is useful. It comes up naturally. I don't. Pete looks so bad.
He's just hanging his head in shame,
synthesis,
anger.
I think we don't like it because I said it like 15 times in a row. That's got to be
that's
it,
exactly it. And you paid your brother to say it on the air.
He did not.
No such thing. James and I talk twice a year, and it's for 5 seconds to say, "Are you dead?" No, great. Don't talk to me again. There's no way I would have told him to say synthesis to you, which just means so much to me that he did, because it means that, well, first, I guess he's heard us say it, but two, it means that watching you squirm is a delight to him as well. Delicious.
Yeah,
Delicious.
You guys are the worst.
Are we?
So, anecdotally, I know that we just came out of a hike with my kids. We took a hike around the Smoky Mountains and just got home. And the ride home, they were laughing so loud in the car. And I remember someone saying, "We're jolly after we are hiking," or something like that. We're jolly. And I thought, man, it was like magic. And I didn't at the time attribute it to physical activity, but I tell you what, after being in the Smokies, and hiking for a few hours and then coming back and sitting in your car, you're happy to sit in your car and you're happy to be there with people. You might be tired, but in this case anyway, a quick afternoon hike did wonders for my family. If we're talking about being at the beach all day,
data and synthesize a good outcome.
Yeah.
Speaking of hiking though too, I mean, it's interesting, like my youngest son, we went on a hike in the summer to, I think it's Bear Lake in Rocky Mountain National Park. There's like a hike that goes up and you pass 3 or 4 different mountain lakes. And my youngest son was like horrible the entire, he's like, "I hate this." Just like literally like that the entire time as we're walking up. And then we get back,
a pretty good growl too.
We got back down to where we were staying, where we camped the night. And he was like, "That was awesome. I loved it." I'm like, "Really?"
Oh,
But
man.
I think, sometimes doing those like exercise, maybe you don't enjoy it or the physical activity, but I think still had the benefit of it afterward and just felt better afterward.
Yeah. Yeah. I guess final question that I have for you is, so you mentioned there's still a stigma that exists against mental health, and you are in one of the least stigmatized professions. I think people are generally like, "You're a doctor, I trust you." What would you recommend people do in general to push against that stigma?
To recognize or see that they're not alone, that even the person sitting across them may be struggling with those exact same issues and they just don't know it. That I think, depression in particular is so isolating, and having a sense of connection with other people, and realizing that they can still have a normal life, a fulfilling life in spite of their mental health, that it's not something that you need to hide from. It is health. Just take away mental health, it is still health, and it has a huge part in your overall physical well-being as well.
Yeah.
Thank you. That was great.
I feel like one of the great gifts of my job, and I'm sure you both can kind of relate to this, is I feel like everybody that I've talked to has 2 things in common, which is that they're capable of suffering more than they can let on, and they're capable of so much more greatness than they realize. And I feel like everyone has, if we could just find ways to share that with each other, like I really think community is one of the great catch-alls of all these things. I mean, you look at like how schizophrenia, for example, is expressed regionally, and it's done differently in different countries, and outcomes are different in different countries based on how the community treats the person with schizophrenia. I mean, there's a book about schizophrenia in Ireland, for example, where everyone wraps around completely. If someone has schizophrenia, the entire community goes, they might be schizophrenic, but they are schizophrenic. And so there's room made for that person. Very rarely, if ever, does that person lose housing, lose connection with reality. It tends not to fall apart the way it does in America. They never lose access to services. They never lose access to I mean, like, it just, that communal approach to it is the difference between their lives falling apart and them being able to function as human beings. And I think that's true for depression, anxiety, trauma, you name it. If you can get a community, and I don't mean a community where like, hey guys, let's all get together and suffer, but I mean like, I accept you as a person who has this thing, and you accept me as a person who has my thing, and together we are wild stallions. You know, like it just works out really well.
Yeah.
Thank you for coming, James. I really appreciated your perspective and the stories you had about the physical side of health.
Yeah. Yes. Well, thanks for having me on.
Yes.
Well, as always, thanks for having me on.
Yeah.
Pete, nice to meet you.
And nice to meet you, James. Like, thanks for being here.
For the sake of Mom, maybe just a little bit, but also just because I crap on you so much, I would like a recording going out where the world has proof that I actually love you to death, James. I'm so proud of you. You're one of my favorite people. One of the great lamentations I have is that we don't live close to each other. If just because I'd like to make music with you, but even setting that aside, you're just a good hang. And so,
thanks.
Yeah, man, I love you to death.
I love you too, man. And I'm glad that, because when we were younger, we hated each other pretty much. Like we fought a lot. But I'm glad that did not stay that way, because you're fantastic. I love you, man.
For sure. Pete, you're kind of a disappointment. Anyway,
That's all right.
Let's sing, you guys.
Love you guys.
Love you so much.
Bye.
See you.
See ya.